So we're back talking about prolapse again. And so if you're a woman who believes you have prolapse, something's falling out of the vagina, something bulging out, the best place to have that evaluated is by a fellowship-trained urogynecologist, pelvic surgeon, who can evaluate the vaginal tissues and determine if you actually have prolapse. We'll identify the stage of the prolapse, if you will, the part of the vagina that's falling down for the prolapse, and who can then talk to you about methods for fixing the prolapse. There's vaginal approaches, and there's abdominal approaches, and among the abdominal approaches, there's so-called open approaches, which is with an incision, and there are also minimally invasive approaches, which are laparoscopic, and more often than not, in this day and age, they're robotically done. The vast majority of these repairs abdominally are done with the surgical robot. To get these done correctly, the gold standard for prolapse repair is a procedure called an abdominal sacrocolpopexy. And that usually involves using a graft to suspend the vagina and tack it down to one of the strong ligaments that won't break way up on the inside of the abdominal cavity. When that's done robotically, that works really well and a good long-term solution. For women who decide that the traditional mesh-based approach for the sacrocolpopexy is not something that they want, they don't want synthetic mesh, I want to reassure you that there are non-mesh solutions that are available. We pioneered a version of these that's durable here at the Pelvic Floor Institute. They work very well. We've done hundreds of women's surgery with them, and we've had excellent results. It is also a robotically placed procedure that works as well as the synthetic mesh, but the advantage is there's no mesh involved. So if you're interested in such a procedure, please do not hesitate to come see us here at the Pelvic Floor Institute in Tampa Bay, and I'm happy to provide a consult for you as to how we can do your durable, successful, long-lasting, non-mesh-based prolapse repair surgery using the surgical robot. So I get the question from my patients quite often, what is prolapse and how is it treated? Is it safe? Is it life-threatening? What's up with it? So prolapse is nothing more than the vagina, which is a long tube, turning inside out on itself. When the vagina turns inside out on itself, it can look like something's falling out from between the labia or the lips of the vulva. And when that's the case, some symptoms associated with that are like as follows. Sometimes your bladder won't empty well. Sometimes you have to pee a lot. Sometimes you're leaking urine. Sometimes the bulge is getting in the way of walking and activity or even intercourse. Sometimes you can't poop very well. Sometimes you have to put your fingers on the perineum in order to help you evacuate your bowels. Those are some examples of some of the symptoms of prolapse. Pelvic pressure, worse at the end of the day. After a long day of standing, the pressure, low back pain feels really intolerable. Difficulty emptying bowels, difficulty emptying bladder, leaking stool, leaking urine. Can't get in sexually, for example. So those are some of the symptoms that are associated with it. Real brief, treatment for prolapse can include do nothing because it's not generally a life-threatening matter. Many women will refuse to live with the symptoms of prolapse because they're intolerable. And you need to be aware that there are non-surgical solutions, which include placement of pessaries, which are little donut-like devices, rings that go inside the vagina to help hold things up. They work kind of sort of well. They're not the best long-term solution, and they can have their own collection of side effects. There's surgery that can be done through the vagina if you really importantly want to have your prolapse repaired, and there's surgery that can be done through the abdomen or with the surgical robot. The gold standard for surgical repair of prolapse is an abdominally placed graft that can hold the vagina back into place, and that is usually done robotically or laparoscopically these days. The most important thing for you to recognize is if you think you have symptoms of prolapse, the best way to proceed is to find a fellowship-trained urogynecologist who's experienced in the diagnosis, testing, treatment of female pelvic organ prolapse. That's sometimes a person trained through the gynecologic pathway or through the urologic pathway. That person can help diagnose your prolapse and can design for you an appropriate treatment that involves either non-surgical or surgical lifting of the vagina. And these surgeries can be very durable. I get asked a lot by my patients, well, are there other non-invasive techniques? Can you do PT, for example, physical therapy of the pelvic floor to help with prolapse? Well, it turns out prolapse is a mechanical problem. The flag fell down from the flagpole. you have to pull the flag back up and put it back into place. That's a mechanical solution. Physical therapy can be a stopgap solution because it can help close the pelvic floor opening to try and hold the prolapse into place. That does not work in the long term, but it certainly can be a short-term effort to try and solve the uncomfortable bulge in the shorter term. It will not last forever. So if you think you have symptoms of prolapse, bulging, pressure worse at the end of the day, can't pee, can't poop, leaking stool, leaking urine, difficulty with intercourse, it's important to find a fellowship-trained urogynecologist. Here at the Pelvic Floor Institute in Tampa, we treat prolapse surgically, and we also use non-mesh or mesh-free methods for durable solutions to your prolapse if you choose to have or opt to have a surgical treatment. So pelvic organ prolapse is nothing more than a turning inside out of the vagina. If you think of the vagina like a long tube, like a sock, that's pulled up on the inside and held in place normally by ligaments, that tube then pulls inside the body, flattens out, and then the front part of that tube holds the bladder up. The back part of that tube keeps the rectum in place. And the top of that tube basically helps to hold the uterus and cervix in place. So when you think about prolapse, it's the ligaments that are holding the vagina up that stretch or break that allow the vagina to turn inside out on itself. And in fact, what can happen is that preferentially, the front part of the vagina can be turning inside out on itself or falling down. And remember, the front part of the vagina is the part that supports the bladder. So when the bladder and the vagina are falling down together, that's sometimes called a cystocele. Remember that the back part of the vagina helps to keep the rectum in place. So if the back part's turning inside out on itself, that's sometimes called a rectocele because the rectum's coming down behind it. And then if the top part of the vagina is coming down and the uterus is in place, that's usually called uterine prolapse. And if there's no uterus after a hysterectomy, usually what comes down with the top part of the vagina is the small bowels, and that's called an enterocele. What's happening in every single one of those cases is that the vagina itself has weakened and is turning inside out on itself, and that bulge is what's called prolapse.